Yeah. By the time we're done with this, you'll understand.
By the time we're done with this, Scott, I'm not going to understand anything because I'm a bad medic. It's just that Trent doesn't know enough terminology to call you on your which is why I'm here. Welcome back to the podcast, everybody. We already had to have a single cursing thing that is going to need to get clown horn out. So welcome, Scott Zastrow, Captain, PA, former 18 Delta extraordinaire. We've talked to you before, but what we're about to talk about, you hate tourniquets. Let's just get into it. What's up, buddy?
How you doing? We're gonna have a little plan. So it's not, I'm just gonna talk about how shitty tourniquets are. We're gonna kind of talk about military medicine in general and what's good about it, what's bad about it, the whole nine yards. Like I said, I came in the Army in '89. I did 28 years. I started out with a 68 whiskey. There's a 91 Alpha back then, but 68 whiskey. Went to selection, became an 18 Delta, did that for 18 years, and then went to PA school in 2007 and been a PA for 15 years now. I've been on, multiple deployments, combat and non-combat, Somalia, Djibouti, Bosnia, Ethiopia, the Dababa refugee camps in Kenya, the Afghanistan, Iraq, JTF fits around the country, whatever. Yes, sir.
I'm wondering, is this the first time in podcast history that someone has admitted to being on a non-combat deployment?
Right. How dare you? I can't believe it. Yeah, you're not supposed to do that.
For 10 years in the 90s, like all we did was JTF sixes and, Iris Golds and, doing a lot of fit around the world and, going to demining in Ethiopia, go to Somalia and work with and, set up a sniper school. We did a jump school in Djibouti. There's just a lot of different things that we, in Bahrain, like we just all over the Middle East, just doing, like, 'cause I was in fifth group. So we did a lot of stuff in the Middle East. So it was literally just trip after trip after trip after. You're still gone 6 to 9 months a year. It just, there was no combat ops going on. Luckily, I got to go on a combat op in Bosnia and got to see some stuff and, met my first CCT guy, which I love. Alex Hunter, got to give him a shout out. But most of that time was in fifth group. I did my residency at Fort Campbell, which is super cool. I got to go down at Vanderbilt all the time because, they work with the military guys. And then I met the trauma surgeons down there. Was able to get specialized in trauma management and got to do a fellowship at trauma at Vanderbilt, which is super cool. I learned a lot there. And then went and, immediately did a deployment with the 101st and then, did a couple with 7th group. And so I got to work at, point of injury. I got to have a role 1 where guys were evacuated me. I got to work at the FST and see the trauma surgeons that were forwardly deployed. And then I got to work at, Kandahar at Brown at the role 3 and actually be the guy that received guys coming off the line. So I've seen pretty much every level of whatever. So, let's just talk about military medicine and the good points and the bad points. When I say military medicine, let's talk our level, right? Like my level and below. So the unit doc and the medics that work with them at point of injury. Like what exactly do we want, from us and below, right? And the biggest thing we talked about it last time, the 2 things that docs want you guys to be able to do is to work with your hands and speak our language, right? And because speaking the language is almost as important. Like any moron you can teach Trent probably knows how to do, TCCC, right? Like it's not, they're not that difficult to skill, right?
Am I the moron in this situation?
Whatever.
Yeah.
All I heard was you're like any moron.
Trust me.
Trent, even Trent.
Yeah. Trust me. When we're done, we're all going to think we're morons, right? But the whole gist of medicine and even in a hospital setting is collecting data and passing data. If you can do something there while you're there, that's good, but it's all going up the chain to the subject matter expert, the end state user, whether that's orthopedics, cardiology, dermatology, psych, or a trauma surgeon, right? It's all us at the user, and that's why they have mid-levels. That's why they have nurse practitioners, DOs, PAs. Like our job is if we can handle the 85% nitnoid shit, like the twisted ankles and the coughs and sneezes and headaches and whatever, that's fine. They don't want us to bother them with that shit. But when it's something real, we have to collect data and pass it to them. And the biggest part is you'll learn, like when you guys did your little residency thing when you worked around the hospital, is that each one of those specialty care people speak a different language, right? Like the derm guy wants it, give me primary lesion, secondary lesion distribution. The trauma guy wants ABC. The orthopedic wants special tests, neurovascular, what, like you have to learn what that particular guy language is, and then you can take the data that he's going to be looking for, put it into a speech, and then present that patient to him. Trauma is the exact same way, right? If you're forwardly deployed as a Delta or a PJ and you're out at a VSP, and I'll give you an example, right? Like we had a dude call me up. They were doing combatives for for PT that morning. The guy put him in a Kimura and snapped his shoulder, right? Like pretty fucked up. So the guy called me and he was like, hey man, we were doing composites this morning, put him in an arm bar and he freaking, twisted his shoulder. I'm just trying to figure out, can he go out? Right? Can this dude still operate? Can he still go out? And I'm like, okay, well, what happened? What was the mechanism of injury? He's like, I put him in an arm bar. So I'm thinking hyperextension of the elbow. And I'm like, how does that affect the shoulder? And he was like, no, I arm bar is kind of twisted up and behind him. And I'm like, what are you talking about? Twisted up behind? You know what I mean? Like, and so what happens in that scenario? What do I say? I'm like, put him on a truck and send him to me. So let me check him out. Right. Sure enough, they put him on a truck, truck hit an IED. Luckily, nobody got killed, but it fucked up some people. You know what I mean? So your stupidity led to a situation that could have caused a catastrophic event and it didn't. Right. But what is a Kimura, right? Like talking to you here, you know what it is because you do BJJ. So it's the arms at 90 degrees of flexion, right? The elbows at 90 degrees of flexion and it's hyperextended. Right? If he would have just said that, I would have been like, okay, shoulders at 90 degrees, elbows at 90 degrees, hyperextended. Yeah, externally rotated. Bam. I'm like, okay, probably supraspinatus, put him in a sling and swath and give him some shit, put him down, put some ice on it, whatever. Like, it should be fine. But you have to be able to present that to me in a manner that I understand. Does that make sense? Trauma is the exact same way, right? So it's about collecting data and passing data. So while I was going through the PA program and doing my shit at Vanderbilt, I told you the story about Tim Nunez and calling me 3 deep in the whole 9 yards. That was kind of a changeover for me because I didn't know how to present whatever. And we'll talk about that in a second about when we start talking about the actual medical stuff. But I would go to him and I'd be like, you see all these things at point of injury, like they're doing these different things. Like what do you want us to be able to do? And he's like, I don't really care. You know what I mean? Like you guys, if you do nothing to them, you're still going to bring him to me. I'm going to do my job. If you zap him and wrap him and it's all fucked up, you're going to send him to me. I'm going to do my job. If you zap him and wrap him and everything is perfect 100%, I'm going to cut it all off and do my job. So he didn't really care. He's like, I don't have time as a trauma surgeon to get into the point of injury care with you knuckleheads. So what do we do without that, guidance and mentorship? We create it ourselves, right? Like, and that's the problem, right? So I go to them and say, what do you want us to do? It's not what you want us to do to support that we could do with them. It's what do you want us to be able to do when you're not there? Like, what are the skill sets you want us to do when you're not there? How do I support you? You know what I mean? If before they get to you, right? Cause you have to remember that in what we do, as much time as the military at, with 68 whiskeys, 18 deltas, PJs, whatever, all the time that we spent into that point of injury care, that's like 1% of that trauma patient's life in the system, right? Because you have point of injury, then they get on the bird, then they go to the roll 2 or the roll 3, they get surgical washouts, they get on a bird and they go to launch stool, then they get on another bird and they go to freaking Walter Reed, then they go to the, do some rehab, go to Center for Intrepid. Like that might be 2 years. So that 10 minutes that I'm working on a guy, right off the bat is almost insignificant.
Right. Is he alive? Did he get to the surgeon? Like that's,
and we've
team members. That's always what we say, right? Yeah.
Right. And you can read in the first page of the Ranger Medic Handbook, right? Or the 18 Delta Handbook that there's 3 types of casualties, right? Like no matter what you do to this guy, good or bad, he's probably going to live. No matter what you do to this guy, good or bad, he's probably going to die. And then what you do, good or bad, is make a determinant between live or death. And that's a small percentage of those 3, right? Like we have the data. It's very clear, right? So remember, I was in the early 90s before TCCC, right? So you kind of have to understand how that transition changed. So TCCC, what is TCCC? How was it invented? Why did it call it? It was, there was an article in 96 by a guy named Frank Butler, who was a kind of a researching doc, right? Like the dude was a FAAO, which is a fellow of optometry. So this is an optometrist who wrote this article and changed how the military did trauma, right? And we're like, why are we listening to an optometrist, right? Like,
right.
Because he was one of those research guys, right? So we put together a lot of data. You can go Google it. It's just Google TCCC Frank Butler 1996 and you'll be able to read his stuff. And it was, it talked about SEALs on the thing. At the end of the day, what happened was tourniquets are not bad, right? Like that was his thing. Like these are a valuable tool. that we can use on the battlefield to stop people. And it just like the world exploded, right? They created a TCCC committee that these guys have been getting hundreds of millions of dollars for the last 50 years, right? Like I'm not going to call it a boondoggle, but at the end of the day, it's what is the difference between the reality of real medicine, which is every doctor, 65,000 strong, does ATLS, right? The standard in trauma in every trauma center, every emergency room around the country is ATLS. We are like, ATLS will get people killed in combat. No, it doesn't. That's the dumbest thing I've ever heard. What?
Can you do me a favor? Just people might not know what ATLS is. So it's Advanced Trauma Life Support. So that's the program that we're using to treat people for trauma.
This thing. Yeah. And it is that when you go to work in any trauma center or whatever, it's a book about this thing and it's advanced trauma. They have courses that you can go to that are about 2 weeks long that doctors go through and rotate through. Just like, we used to go through TCMC, which is Tactical Medical Combat Casualty Care course for providers before we go downrange. It was run in San Antonio. It was only a week long, but it was just kind of a quick TCCC, but in a clinical setting, like if you're in an aid station, people get evacuated to. So instead of point of injury stuff, it's like, okay, they're evacuated back to you. So it's the same kind of stuff, but it's a book about this long and it's just the Bible of trauma for civilians, right? And so they're like, we're like, oh, we're military people. We do things differently. ATLS will get people killed in combat. So they redid it and they created what's called TCCC, right? So what is TCCC, right? Like that's what you have to, understand what TCCC. Let me see if I can get my slides.
It's tourniquets and special gauze, right? Isn't that what TCCC is?
Yeah. So TCCC is pretty much, they came up with care under fire, tactical field care, combat,
medevac, TACAVAC phase. Yeah. Care under fire, expedient field care, and then your medevac phase or your 3 phases of TCCC.
Right. So, but let's look at what is care under fire, right? Like what is care under fire, right? There's 7 steps to care under fire. Do you know what they are? Like, I'm not gonna
shoot back. I don't know. Shoot back, self-direct care. Like, I mean, it's like the super most basics. Like it's a tactical problem.
Until number one is return fire. Yeah. Right. Number 2 is direct the casualty to remain engaged if he can, right? To direct the casualty to move to cover, right? Keep the casualty from sustaining, further wounds. Like none of these have to do with anything with you touching the patient yet, right? And then the middle one, number 5 is stop life-threatening injuries with a, if it's feasible, either by self-aid or throwing on a tourniquet. Right. And then it says airway management is generally deferred until the tactical field care part. Right. So in essence, care under fire is just like, keep fighting, throw on a tourniquet if you can. Right. And then you go into, tactical field care, which is that. So in essence, if you're not being currently shot at, or as soon as I pull this guy around the corner, I'm no longer under care under fire. Right. And then you go into tactical field care, which is what? ABCs, right? Like it's airway, breathing, circulation, whatever, you know what I mean? And obviously in the last 10 years or so, they switched it to March, right? But let's look, what is the difference between ATLS, March, TCCC or whatever? You have to understand that the only thing that determines, it's the sequence. It's March is, massive terminate airway, circulation, whatever. Saying things like March, TCCC, ATLS or whatever, all that tells me as a provider that works in trauma is where you were taught, right? So if you say March, I know you're probably a military guy, right? Because that's who uses March, right? Like if you go to TEMS, Tactical EMS in Vegas, they're going to do a different acronym. If you go to OEMS in DC, they teach chem, right? So they teach circulation, then airway, then breathing, right? Like at the end of the day, it's all of it is Fugazi, right? Like it's all still ATLS. We're just like, we do ATLS, but in essence, we're going to turn. Is that even really necessary, right? Because I can tell you, I've been doing this my whole life and I have an incredible amount of experience with my hands touching individuals who are injured. And I can tell you, I would be like, hey, Trent, put a tourniquet on, like, I'm going to do ABCs, right? Like at the end of the day, it's still just, it's all kind of melding together if you have multiple people doing it. Cause in the trauma suite, right? Like I remember at Vanderbilt, it's a teaching hospital. So like Tim would put me up in the throne and just have me run the station. And I would have students all the way around the casualty, when they come in off a helicopter from another hospital, they come down the elevator, the trauma nurse would give us the brief, and then they'd put him on the bed. And then I would just dictate, okay, you do this, you do this. But there's like 9 people standing around this guy at a table, and it's all kind of happening at the same time. So the tourniquets are getting put on while he's getting an advanced airway, while he's getting his clothes taken off, while they're taking the vitals and getting them out of. So the whole what you do in what sequence, it doesn't really matter. You know what I mean? Like we know the reason that we say tourniquets are good and we should put them up front and whatever is because that we determine that massive extremity hemorrhage is a preventable cause of death on the battlefield. Like that's the reason, right? Like, and that comes from data, and we'll talk about that when we talk about the tourniquets, right? Like that's the reason that they said we can now use tourniquets. It's because it solves the problem of a preventable cause of death, right? And it's just a quick fix problem because we can just throw it to Trent. He can have him on his leg. He can throw a tourniquet on and be like, I'm done. Doesn't really matter if it works or not, if it whatever, right? So the problem with all this is that we get that data and we kind of create it ourselves. So in the military medicine system, we have NCOs teaching and we have enlisted teaching enlisted with very little input from medical providers or whatever. And there might be a unit doc or whatever, but the medics are over there teaching medic shit and doing ATL, doing their own, like whatever thing, you know what I mean? Like I've been through many military, scenarios where they had me come in and teach, and then I would watch them teach, and I would just come do a class. And the dude would, everybody keeps a tourniquet in their cargo pocket, and every once in a while the instructor would yell out left leg, and they would drop to the ground, and the guy would pull out the tourniquet and throw it on the left leg.
Classic.
And so in essence, you're just training guys to throw it on as fast as they can, regardless of, because they're not tightening it and they're not doing it correctly. They're training on them to put it on kind of half-assed in that scenario. And I was just like, okay, I need to kind of, put the kibosh on this, right? So let's talk about, now we'll get into, exactly why that's not good, right? So in medicine and in teaching medicine, there's kind of a triangle of knowledge, right? You have the instruction of me teaching you a class, and then you go down to this part of the triangle, and it's you performing what I just taught you. And then you perform that. And after your performance, we collect the data, which is over here in this part of the triangle, right? So you have instruction, performance, and then data. And then that data, if we collect that data, we're like, oh, we have this data, so we should change the instruction now. And that'll then change the performance, which will then change the data. And it's a continuous loop that we do. That's what we do in real medicine, right? We're like, okay, we were taught to do this. Well, and then they go do that. And they're like, well, that's not getting the exact result. So, so they send that data back up, and they're like, oh, well, if we change it to this, then they perform this and then change the data, right? So, but that's not what happens. In military medicine, they teach you perform, we collect the data. Then us as providers get together and we go through all the data, and we're like, man, this isn't working and this isn't happening. But that never gets back to the instructions at either Fort Sam, Fort Bragg, Fort whatever. You know what I mean? So it never changes the performance. Like I've done multiple deployments, and from the last one, I was the first one there. And I can tell you from the first time I was there to the second, to the third, to the fourth, to the fifth, to the sixth, I knew, because I have been in provider circles, that the data was coming in and the data was changing, and we were getting really good data from point of injury. Like we were really good in OEF and OIF of collecting the data. But the second and third and fourth and fifth and sixth trips I went on, the medics are still doing the exact same thing they were doing on the first one. So I'm like, how are you guys still doing this? Why are you still using cats? Like, this is insane. Like, you shouldn't be having that. And it's because the data was never getting back to the instruction, which never filtered back down to the user level and never changed the way that they perform, which is insane, right? So this is how so the best way to explain it is like martial arts, right? I'm talking a language you can understand now. You go from white belt to yellow belt to blue belt to brown belt, whatever. It's a progression of skills, and each one is a gathering of the skills you learned as a white belt and then adding to those skills, right? So I'll just put this up here. I don't know if you can see this. This is how we do sports, right? From beginner all the way to the instructor level. You learn skills as a white belt, you collect them. And as you go those skills, you go test out to the next level. You learn more skills, and all these are together in this one. You add more into these, right? But what do we do when we teach classes? Oh, today We're going to talk about needle D's, tourniquets, chest tubes. What we just start throwing random skill sets at people, and it never really builds up into a progression of what. So what would the white belt be in medicine? Be the right, like the Trent's, he does a TCCC class, he gets an IFAC, whatever. Well, that's a white belt, right? You're not even in medicine, right? Like it's the user level guy, whatever. He goes to a, combat lifesaver course or whatever. Like that's a white belt. The yellow belt would be like a 68 whiskey, right? Like that, the medic's starting to learn stuff. And then, you know what I mean? Like those are the different levels of care all the way through a trauma surgeon. So, and then you can break it down into me and you, right? Like as an 18 Delta and a PJ, what is our belt system, right? Like our white belt would be an unconscious atraumatic patient, right? Like give me an assessment and a presentation of an unconscious atraumatic patient, right? He's got bilateral chest, atraumatic chest, atraumatic limbs. You know what I mean? Okay. And you tell me and say, okay, Scotty, what do you got? And I'm like, I have a guy that, I don't know what happened. I walked in on him. He was naked in the shower down. He's got he's maintaining his own airway. He's got atraumatic chest, atraumatic limbs. He's responsive to painful stimuli. He's fully exposed and he's got a radial pulse. There's your ABCDEF, right? Like, so the presentation to you or to that, me taking him to and people are like, oh, well, he doesn't have any trouble. Cause I would do that to my medics. I would just put down a dummy naked and I'd be like, do your thing. And he's like, there's nothing wrong with it. I'm like, yeah, you're right. Cause paramedics always come up on gunshot wounds and amputations. They never come up with a dude just passed out in the street.
Right.
You still have to do a primary and secondary survey on the guy.
Yeah, this guy's fine. It's the old PJ standing.
You still have to.
Yeah. You okay? Hey, this guy's just laying here.
Yeah. But you still have to collect him, transport him, collect some data, and then pass that to the doc when you get to the ER. Mm-hmm. Right. It's not like, I hate telling you this, but when I was teaching, we used to use, inside combat rescue as our examples of what not to do. Right. Because if you go back and watch that, when we're done with this,
there's nobody that's happier to hear that. Why would you hate telling me that? I hate that shit too. What's up, Hanson? What's up, Lieutenant Colonel Hanson?
TV show. Yeah. In that TV show, you showed 18 Deltas transferring patients to the PJ. Horrible presentation. Then you showed the PJ not doing a primary and secondary survey on the bird. And then you showed the PJ dropping it off and giving the brief to the ER or the roll 3 when he gets there. And I've heard things like, what you see is what you get. I would fire you if you dropped a guy off with me and said, what you see is what you get. Right? Like, why do you even exist if you're not collecting that data and passing that data, letting me know prior to getting there what is coming my way? Right. So think about it like this, right? Like you've done the same thing I've done, right? We've done, Go Lab or whatever. And I'm talking 18 Delta stuff, right?
Okay. Let's mucho going around the corner. Don't put me in your category here.
Right. But you're going around the corner and you're about to be tested in, right?
Right.
You're going around the corner and there's going to be a casualty waiting for you there. Here's your aid bag. When I say go around the corner. However, and then you just did your thing. But before you got there around the corner, if I just was like, hey, Aaron, your casualty is around the corner. Hang on a second, right? He was hit with multiple gunshot wounds and an IAD, right? He has no potential airway. He's got penetrating wounds to the chest. He's got a below the knee amputation of the right leg. He's unresponsive and he's got a weak thready radial pulse. Take a second to gather that and then prep yourself. That's a game changer before you walk around the corner. So if I know that I have a thoracic injury coming my way from the bird and you present that to me over the phone on the way, I'm going to be like, hey, get me a chest cracking kit in bed 1. Like you know what I mean? I want O negative. I want 10 units of O negative blood standby. I don't want to realize that while he's on my table because that's a delay in the treatment. But because you didn't collect the data and pass the data, you just screwed this guy out of 4 minutes of treatment, which could be a lot, right? In that setting. Right. So think about it like that. So the presentation is almost as important as what you do with your hands on the battlefield. Does that make sense?
It does.
Right, so now let's talk. So going back to the data triangle thing, right? Remember that a lot of the data that we got during combat was essentially skewed because of the anecdotal data sets in theater, right? The surgeons involved clearly identified this problem in the course of the reports, but there's little recognition that the anecdotal stories were the things that caused huge change, right? Like Butler writing a thing saying tourniquets are okay, completely changed military medicine and TCCC because of one little article, right? Like those are very anecdotal things that it didn't have a lot of data in there. You know what I mean? Because remember the sample set, right? Like there's not a lot of accuracy with during the initial phases of combat and data collection about what's happening on the battlefield with medics and this stuff. There's not a lot of accuracy in that, right?
Yep. So I do have one question here because I want to get your opinion on something, and I'm sure you tee up. It's actually in line. It's not a tangent this time. So the book that we hung our hat on, and the book that everybody always freaking quoted of all time that like changed the way that we did military medicine was War Surgery in Afghanistan and Iraq. How did you feel about that book?
It was good because it had a lot of data in there, and it talked about the death triad, which is super important. However, that book was more written for us at the roll threes, right? Because it talked about, we were getting a lot of fungal infections because in the IEDs and the mind blast trauma. It talked a lot about mind blast trauma. It talked a lot about, hypothermias and stuff like that that we could do. And at our level, is there anything that you can do in there that can transfer to the user level at point of injury? Not really. You know what I mean? Like, I mean, the biggest thing that I want to kind of get across today in this little talk with us down here below the smart people is we have to accept that we are not great, right? Like we're not trauma surgeons. We're knuckle draggers that are there to plug holes, keep the airway open and transport them to the smart people, right? Like, cause remember, anytime somebody comes in there that has any kind of penetrating wound whatsoever, they're going to need a surgical washout, regardless of what it is. Right. Like, so, I mean, and that goes back to what we were talking about before with the belt system, right? So for me and you, unconscious atraumatic patient, right? And then unconscious atraumatic patient with a Hodge or a buddy, a battle buddy. So you got two guys doing it. And then, a little bit of wounding, treat that and then present, and then wounding with a buddy and present. And then all the way up to multiple casualties with a buddy. So you have a stair-stepped way. And then that's phase one. And then phase two, you would go into the clinic and somebody would do it initially and then bring them to you and they would drop you off in the clinic with an unconscious atraumatic patient, then an unconscious atraumatic patient with a buddy, and then a trauma patient, then a trauma patient with a buddy, and then multiple trauma patients and multiple trauma patients with a buddy. And then at the end, the black belt is you would be able to teach that entire thing to multiple people, right? Because what is the end goal of you at point of injury is going to be the phase one part of that, right? You want to be able to do multiple people with, one or two guys and have the whole thing and then be able to present that, when a PJ comes in, I have 5 casualties. Casualty 1, these guys involved in fire wipe and you just rank them by worst to first. And then, casualty 1, he's got an NPA for his airway. He's got an atraumatic chest. He's got bilateral amputation below the knees, treated with tourniquets. He's got, you know what I mean? Instead of, I know you guys like to touch places when you're getting tough, but you should be able to transfer them and explain to them what they got. And they should be able to just have a piece of paper that says A, B, C, D, E, F, and they're just jotting down the injuries on them. So you can then identify. And I'll give you an example of why that's important, because we had dudes come into the roll 3. There was multiple casualties and a KIA. And you got to remember that our boys come in, they all look like bad guys. They're all wearing what they want. They got beards. They're dirty as shit. The stuff's been cut off of them already. The only reason that they're Americans is because they got sleeve tattoos.
Yeah, I was going to say the tattoos are in English. That's the only reason
we had
they got tattoos at all. Yeah.
Right. And we had a KIA, but it was IED strikes. So they were all covered in dirt and whatever and treated. And I go in there and of course I'm working on these guys and the colonel comes in and he's like, Scotty, who's my KIA? And I'm like, I don't know because your medic's a moron. Had he given me a good presentation of all 3 casualties before they got here, I would have known which guys had which.
And who needs treated first. Like, that's the thing that I can't foot stomp enough. And this is what I used to tell to my students all the time. I was like, man, I don't expect you to be a shit hot black belt medic yet. I don't expect you to be able to manage like multiple, like we always brief that, a young pararescueman fresh out, he's supposed to be able to manage 2 multi-system trauma patients at once, right? Like that's what we brief out of your med rec. I'm like, guys, man, I don't know if you've ever dealt with a multi-system trauma in your paramedic rotations, but I'll tell you straight up, it's fucking hard. I don't expect you to be able to just absolutely crush that. Right. But I do expect you, the second that you're ready to turn that patient over, you have to speak in the doctor's language. You have to present the information accordingly. And that has to be the best part of your treatment, because honestly, you can kill somebody by misrepresenting what's going on with the patient, because the doctor might be like, okay, well, out of these 4 patients, just like you're saying, these 3, I think, are the most critical. And if you misrepresent that and they put somebody further down on the treatment algorithm, that could be life or death. It's that important.
Absolutely.
And it's not hyperbole.
And I really, man, that's why I said when I started this speech off that the two things I want you to do is work with your hands and speak my language. The talk is the key, man. I mean, as a PA, when I go to a doc, like I'm not doing surgery and I'm not doing, in essence, we're not even allowed to diagnose shit.
Right.
We can say, I think that this guy's got an ACL tear, but it needs to be confirmed on MRI and confirmed by an orthopedic surgeon. Right. And I'm like, hey, but I have to call that orthopedic surgeon. I'd be like, hey, sir, this guy came in. This is mechanism of injury. These are the special tests I did. This is what I got off of that. I got the MRI and it says this. I think he has an ACL tear. You know what I mean? Can you see this guy? And he'd be like, okay. But if I was like, hey man, this guy was doing combatives and he tore his knee, I'm pretty sure he's got an ACL tear. Did you get an MRI? No, I've been doing this a long time. I know what I'm doing. He would wear me out. Man.
And the first time that you're wrong, your credibility, the first time that you're like, oh yeah, man, I totally think it's this. The first time that you do that, your credibility, and it might be a small circle, it might be somewhere, but I'll tell you what, I watched one time, I was doing my clinical rotations in Philly, and they're like, we were the first class that went to Philly, but I was in the ER working trauma that night. Like I wasn't on the truck, and I watched a paramedic, like a full-fledged paramedic, walk in with his patient and give his opinion on what it was. It was completely wrong. And when he left, to watch the way that the doctors and the nurses and everybody just savaged him, that guy is never going to be able to he's never going to have the trust of that organization again. And if you do that enough and you get,
we kind of talked about that last time I was a thing about how as a young 18 Delta, you know what I mean? Like you want people to see you in a green beret because it's that insecurity and whatever. Mm-hmm. And in medicine, the same way, because inside, you don't know if you really belong yet. Right? Like when I'm working trauma, I'm around these trauma surgeons who have written books and stuff, you know what I mean? And are like famous. And I'm like, I'm here with these guys. I'm cool. I'm smart. So there's this desire to prove to them that you belong in their space. Right. Mm-hmm. And the amount of times I have been humbled by these dudes, like pull me aside, like, dude, your best bet is to let everyone think you're a moron and then just perform well. You know what I mean? Like stop offering things to try to sound smart, because no matter how you do it, we all know who you are and how you were trained. You're not one of us. So stop trying to be one of us, man. Like just be a great, you know what I mean? And I can tell you that, I work with a lot of 18 Deltas and I taught a lot of them. And I only have one rule, man. Be great at what you're supposed to be good at. Like you're supposed to be good at working with your hands. So be great at stuff like tourniquets and a patient assessment or whatever. Be great at your presentation. I don't need you to be able to diagnose shit downrange, but I need you to be able to, if somebody's sick, or like I had a guy on my, in my unit downrange get testicular cancer and kidney cancer that went to his testicles. And the guy thought he had epididymitis. So he called me and presented, and I'm like, that doesn't sound like a normal epididymitis, bro. Like we need to get further studies and further tests. You know what I mean? Like go take him to the local, Indige hospital and get the following tests. And he's like, oh, like he presented it very well. And it came back and I was like, you need to send this dude home. Like those aren't good results. You need to send this dude home. And he ended up getting kidney cancer and he ended up dying like 9 months later. But it was a really good presentation from the dude from downrange, in that system of gathering data and passing data that led us to that, that diagnosis. So I'm not allowed to do that. So at the user level, it's really good that you teach your PJs, like, look, humility is the key, bro. Like I'm a shooter and that I can also do this. And then when you treat a guy and present a guy, they're like, man, that dude really is on the ball. You know what I mean? Cause I don't want you to be a doctor. I want you to be a shooter. Right? Like I'd rather have my PJs, with their gun up and in a gunfight. And if something goes down, we finish the gunfight and then you and I get together and we take care of as many dudes as we can and get them out of here. But we're still going to do good treatment and present them to the dude on the other end. Right. But remember, at the end of the day, there are super smart people who come up with these protocols and plans of why we do what we do. Right. Like there's a story out there about, there's an MIT physicist out there named Noam Chomsky, super nerdy, smart guy, one of the most famous people in, in intellectual capacities in America, kind of a super diehard, hippie, bleed liver or whatever you want to call him.
You're talking about Noam Chomsky?
Yeah. Noam Chomsky.
That piece of yeah, fuck that dude. I hope he's in a car accident right now. Fuck Noam Chomsky and his socialist. Fuck him.
He was, he was doing a thing where, he was giving a speech at a thing and they were talking about, the inside job of 9/11, right? And he's
Sure.
like, you're right. There's like some people in the space who can come up there, but remember, man, like at the end of the day, there are graduate degrees in this shit, right? That's not how you change things, right? Like in real intellectual capacities, you write papers, you collect data, you do studies, you do peer reviewed journals, you put it out there to your peers and you let them just pick it apart. And, there's graduate studies in the best engineering schools in the country. And that's where the people are smart, right? Yeah. You read something on the internet and all of a sudden it's an inside job and the towers came down. You know what I mean? That's not how real smart people work. And that's how medicine works, right? Like, we talked about it before, like somewhere there's some, super smart doctor that did a meta-analysis of 19 case studies and 10,000 patients. And this drug is the treatment for this thing. And that's how the protocol was created. Not because Frank Butler wrote a thing and said tourniquets are cool now. You know what I mean? Like it's just, it's kind of ridiculous, right? So, and remember, so let's talk about the data of war, right? So what was the DOW rate in like Vietnam, right? It was like the change from the beginning of Vietnam towards the end of Vietnam, the died of wounds rate went from like 7% down to 3%, right?
Mm-hmm.
And so that's a pretty drastic change from the beginning to the end, right? And it's because of the data that they collected, moving the mashes forward, having medics train better, doing things like combat lifesaver and letting everybody carry the little,
and it's experience. I believe you can correlate the DOW also declined at the end of GWAT because we had people that were experienced with actually treating that. The medical services were the logistical chains were short, short.
Well, we all know that, if you make it to a roll 3, your survivability rate's like 98%.
Yeah,
right?
Absolutely.
But you also have to understand that from 2001, we say that.
Hold on, Trent's going to talk. Trent actually has a question.
No, like you go back to like when TCCC was first being brought up and everything. I don't think those were the numbers that they briefed us from Vietnam, because they briefed us some
horrific
numbers, and then they were like,
preventable injuries. It's like 77% or some shit died of a preventable wound or something.
And then they gave us like the first 3 years of GWAT, the Rangers saved like 98% of everybody.
No. I'm 100%. 100%. The Rangers for the longest time, I still believe that they do. They say never lost a viable patient, not one time. That's the claim.
Well, I mean, that we'll talk about that here in a second. We're going to talk about viable patients and
viable patients,
versus non-survivable.
Right.
Well, the data I just gave you is from Understanding Combat Casualty Care Statistics, by J.B. Holcomb. You can look that up. Like, I'll give you all the data sets that you can get this for, right? But you also have to remember that by 2011, they did a study of almost 5,000 fatalities in Afghanistan and Iraq, right? And 87% of them died prior to reaching a military treatment facility, right? And that was almost exact 89% of the Vietnam dudes died before reaching an MTF at our MASH or whatever. So it's almost the exact same numbers from Vietnam as far as getting it. If you don't get them to a roll 3, they're probably going to die. Right? Like, it's serious people. Like, most of the people that die prior to getting to a roll 3, right? And there's nothing that can be done there, right? So the preventable causes of death, like that to me has always been kind of, cause even if you got rid of extremity hemorrhage 100% of the time, you're still going to have preventable causes of death, right? There's like 20 of them, right? We just do the big 3, which is hemorrhage, airway obstruction, and tension pneumothorax, whatever. But even those numbers are skewed, right? Like, how many, according to the Journal of Trauma Care Surgery or whatever, like, you have like almost 1,000 that died from hemorrhage, right? And then you had like 75 from airway compromise. And then you had like 10 that were considered thoracic airway, tension pneumothorax, quote unquote. You know what I mean? Because we're going to talk about how skewed that is too, right? And then you look at the hemorrhage, and, most of it was, extremity, and then truncal, and then junctional, right? Like, those are the 3 categories, with the big one being extremity, right? Like, that's the big one. let's see what else we got. So literally like less than 5%, it says, died from extremity hemorrhaging.
That's
in
and they just
since
the fear,
2011. And that's
yeah, the
because
fear
of
mongering,
tourniquets, whatever.
yeah,
Fear monger, right?
the fear mongering
So
of
the
telling
real
you that you're going
data,
to die.
so the real data is 35% of casualty deaths occurred instantaneously. So like we came on him and he was already dead. So that's almost 40%. 52% died within minutes of being injury. So you have almost 80% of people dying like inside that golden hour, right? Like that's the thing, right? So, but of those 75% of that group, it was already, those injuries were deemed non-survivable anyway. So regardless, most of the people that die in combat die because even if a trauma surgeon was at point of injury, it wouldn't have changed the outcome of that. Right. So when it's not that, hey, medics aren't doing their job. It's just like most of the people who die from shit, they either get stopped and they get killed right away or something blows up and the guy gets cut in half and they're dead instantaneously. Whereas 24% were from a potentially survivable perspective, right? So who decides what is non-survivable and potentially survivable? So let me read you the clinical definition of non-survivable wounds, right? And that is physical dismemberment, catastrophic brain injury, cervical cord transection, airway transection with cardiac injury, right? Thoracic aorta injury, pulmonary artery hepatic avulsion, right? Which is, you have the aorta on the heart, you have the two big ones, the pulmonary artery and the aorta. If those are transected, you're probably going to bleed out super quick. And then you have catastrophic abdominal pelvic injury with either lower lower amputations, like at the knee, below the knee, or with what's called a hemipelvectomy, which is in essence, there is a cartoon out there that we use when we teach, and it's got like a dude, right? Like just a dude, right? Like imagine a bubble guy, you know what I mean? And then the line goes from his feet up towards his abdomen. And then there's a chart next to it. So as the line's going up from his feet to his ankles, to his knees, to his pelvis, the percentage of people who die starts to go up rapidly. So once it gets to the point about mid thigh where there's any kind of pelvic involvement, it's like 4%, 6% survivability, right? So if it goes higher than the thigh, guy's probably not going to make it. Cause then if it gets into that hemipelvectomy, there's massive, volume of vessels in there that are just going to shoot out. You've seen the things where, aorta takes this many beats to bleed you out. A vena cava takes this many beats to bleed you out. A femoral vein takes this many beats to bleed you out, right? Like, so the higher the blast goes on any kind of injury of a blast of an IED type thing, the less survivable he's going to go, right? And we'll talk about that here in a second. So all other injuries than that crew were deemed potentially survivable, right? But then you get things like supply constraints, limitations in evacuation times and platforms, as well as the impact of weather, terrain, environmental factors, enemy, the whole 9 yards. All those things can kind of delay that transport to that roll 3 or whatever, right?
Yep.
So let's do this, and I'm going to share, let me share this slide if I can share this. Yeah. Let me share my screen.
I don't want to jump ahead, but it does seem like anecdotally towards the midpoint to like the second half of GWAT, a lot of the schoolhouses that seemed like they knew what they were doing really started to focus on the evacuation portion of March plus E, because it seemed like people were getting stuck thinking that they were saving someone's life through March and just running through that instead of focusing on the evacuation portion of it.
Right. Like at the end of the day, it doesn't matter what we do at point of injury. What matters is how fast you can get them to the smart people.
Right.
And
right.
the people
you'd run those scenarios.
Right. Absolutely. That's the big, but you don't really have influence on that at your level at point of injury, right? Like that's more logistical things that are people above us. But if they don't get you the resources you need for that, like that's what causes people to die. It's not what, like if they don't, like we just said, 80% of dudes that die on the battlefield die instantly or within the first couple minutes, right? So if
Right.
he's in that 20% that is workable, then, you have to be able to come get him and take him somewhere. That's why we had the rings. Remember the rings in Afghanistan? Like you couldn't operate, like we couldn't go on a hit outside of a 60-minute ring. If we did that, we had to get the SOCOM commander to approve it because there had to have been, and what we would do is we just prepo, PJs at a fob closer, at some little VSP somewhere that was secured that they could, now make a ring there. Like, we'll put them over here and they're only 15 minutes out. You know what I mean?
Yeah. It's
so
like
can you see this picture?
Yep.
Yeah. Trent, can you see that picture? Let's do, I'm going to do Trent here, Aaron. I'll get you in a minute. I'm going to do Trent. So Trent, what do you see in this picture? You see a guy with bilateral amputations with a tourniquet on each leg, right?
Yep.
Yeah. Okay. So what's the first thing that gathers your attention?
They're still bleeding. I don't know.
They're still bleeding, right? So he's got 2 tourniquets on there and he's got pressure dressings on his stumps, but there's a lot of seepage there, right? There's a lot of bleeding there. And look how tight those tourniquets are, right? So, right away you're questioning, okay, if they're there and they're super tight, why is there any bleeding down there, right?
Yep.
Does that make sense?
Yeah.
Does that make sense? So that's the first one, right? So now let's talk about that. So how does a tourniquet work? Like what is the act of tourniqueting? Trent, I'm going to stay with you for a minute because you're going to be a better medic when you leave this place. You're going to be a baller, what do you call it? Combat lifesaver when you leave here. So how does a tourniquet work?
Until I start drinking tonight, it compresses all the tissue in the extremity and hopefully that tissue compresses the.
Let's just stop talking. Stop talking. I don't need any more.
You're already wrong. You're already wrong.
So, the more you talk, the more I'm going to poke holes in what you say. So
I am so stupid.
Compression is the first one. So pressure, right? Tourniquets work by the act of tourniqueting is applying pressure, right? Let's just talk about, so what I'm going to take is I'm going to take your retard verbiage and put it into nerd verbiage. So it's well established in the orthopedic anesthesia and research literature that the optimal guidelines for setting the pressure of a constant pressure tourniquet is based on what we refer to in the business as limb occlusion pressure or LOP. So LOP is the driver of the train, right? Limb occlusion pressure. So let me ask you this. Who uses more tourniquets than anybody on the planet?
The military? No, surgeons. Maybe?
Yeah.
I don't know.
My man.
Surgeons.
Most people are like, we do, sir. We're medics. We use it.
Well, yeah, those are
right? Like
that's
they're doing
closest to me, but
ankles,
then I was
knees.
like, no, surgeries, yeah.
Yeah. They use ankles, knees. They do carpal tunnel stuff. They put tourniquets on so they have a bloodless field while they're doing their surgeries, right? So are they putting on cats to do that?
I hope not.
No, they have these pneumatic ones that are hooked to a computer and the computer determines what the exact LOP is, the exact limb occlusion pressure, so they can have a bloodless field without screwing up the guy's leg, right?
Yeah.
Right? So let's talk about it. What is LOP? How do we measure that? You know what I mean? How do we compute it? What's yours?
Until my buddy can't.
Exactly. Look at Aaron's face. I love that. He's like, I don't know. Like these are, so again, this is how medical people talk, right? Mm-hmm. So limb occlusion pressure is defined as the minimum pressure required at a specific time with a specific tournament cuff applied to a specific limb at a specific location to stop the flow of arterial blood distal to that cuff, right? So how much pressure is that? And that's based off of the
science, fucking chicken bones and all kinds of stuff.
So this is the magic formula to determine LOP. So
what if the guy can squat a lot?
The occlusion pressure.
Legs?
Yeah. So the occlusion pressure is the pressure of the systolic minus the diastolic times the limb circumference divided by 3 versus the cuff width plus the diastolic pressure. Nerdy as hell. Does it matter? Nah, not really. Right? But that's the formula, right? Like that's how that computerized cuff that they use in surgery uses. The computer figures out that formula, determines the exact amount of pressure to be put on that thigh so they can have a bloodless field for a knee surgery, right? So we know this information. We've known it since the 60s, right? The 60s, right? So they did a comparison of the pneumatic tourniquets that they use in surgeries, the cat tourniquets that we use are the regular non-pneumatic ring tourniquets, you know, the ones that they put on for IVs, you know, it just kind of squeezes and bends. It's like a little ring or whatever to see which ones they do. And this is going to blow your mind. So this is that data. So if you can see the A is the pneumatic tourniquet. And if you look down here, it shows you what pressure in millimeters of mercury pressure that we need to get LOP. And you can see there, it's about 200, about 200, 250, right? Because if you see at the bottom, it says cuff width, right? The 0 to 10. So about at 10 centimeters, you need about only 200. If you look at the cuff width of a cat, which is the middle one, you need about anywhere between 450 to 700 millimeters of mercury pressure to get LOP on a limb. Do you know how much pressure 750 millimeters of mercury pressure? Like you've had a BP cuff put on you and they jack it up. You know, we're doing what, 150 over 80. So they might jack it up to 200 and you're like, whoa, bro, imagine 4 times that. You know what I mean? Like it's pretty significant amount of pressure, right? So
I mean, just talking in nerdy pressure shit. So 760 millimeters of mercury, that's sea level, is it not? That's how much pressure the entire atmosphere weighs down in a single cubic foot of space from here until infinity, really to about 50,000 feet.
1 inch wide tourniquet, which is what you saw before, how much it was squeezing that guy's thigh, right? So limb occlusion pressure. So what we know is that tourniquets work based off what's called a width to circumference ratio, right? Which is for any given limb circumference, the tourniquet pressure required to stop the blood decreases inversely as the width of the tourniquet increases, which means the wider the tourniquet, the less pressure you need, right? Like pretty, and you know, that's pretty easy. That's, you know, there's plenty of data out there of that. So there's an inverse relationship between occlusion pressure and tourniquet width, right? So here's the big one. Cuff to width pressure, the width of the cuff and the pressure that's necessary in a limb circumference above 0.5 to 1. So at half, right? Were associated with LOPs of subsystolic pressure, which means if your thigh is this big, if you're a skinny person and your thigh is this big, right? 2 fingers together, 2 hands together, and you use a tourniquet cuff that big, right? Half of the thigh, you can get LOP at subsystolic pressures, which means under 120.
Damn.
Pretty crazy, huh? If you use an occlusive pressure at 1 to 1, so if I used a pressure of a width that much on a tourniquet, which is pretty much almost the entire thigh, you can get LOP at diastolic pressures, which is like 90 millimeters of mercury pressure. And what do? We give you this, which is 2 centimeters wide.
If I had
gives you a limb to circumference ratio of like 0.00004, which means you need 750 millimeters of mercury pressure with this. So right away you're thinking that's asinine, right? And here is this is the chart. So you see, yes, sir. Yes, Trent.
Yep.
Yes, Trent.
So my question is, they've talked about putting multiple tourniquets on at a time, right? But those, I guess I'm assuming that like if I have like 4 tourniquets on my thigh, that's not the same thing as having a single cuff that is 4 inches wide. Okay.
Absolutely not. Yeah, we'll talk about it. So you see on this chart, all the way on the left where it's really peaked high, those are cats. And you see it's above 400 millimeters of mercury pressure. And then all over towards the right, you have the pneumatic cuffs that they use in surgery, right? Like that's the chart that we use. These are right out of journal studies that are orthopedic journal studies, which is why in orthopedics, you go in there and you see, and you assist on a knee surgery or something because you're doing one of your rotations. You'll see a cuff on a guy's thigh that's like that long, right? Hooked to a pneumatic thing with a computer in it, right? There's a reason for that because they're trying to get as limited low LOP as they can by using as wide of a tourniquet as they can. Obviously, we can't take 6-inch wide tourniquets or 9-inch wide pneumatic tourniquets with us on the battlefield, right? Like that's kind of loopy. That's kind of, but there's more. There's more. We're going to keep going, right? So the current guidelines are for any cuff width and a type applied to an upper extremity needs LOP plus 50, right? So whatever the LOP is based on the computer and the mathematical model, you got to add 50 to that as like a backup. And for the leg, it's plus 75. So if it's, let's say if we determine, the computer determines that, on a 60 centimeter thigh, that you need 500, millimeters of mercury pressure with a cat, you need 575 to give yourself a little leeway, right? And so, and there's even more, right? There's even more. What we also found out is that, let me see if I can get this. There was significant differences identified in the BMI of the casualty, right? And what we found out is that the BMI of the ones that the cats failed on, that the fats, like they did all these data, right? Like I'll give you, they did a study with, in the Journal of Trauma that they put cats on thighs, and the self-applied cat was only able to stop popliteal flow in 2 subjects, which was like 6% so it has a 94% failure rate to stop a popliteal artery flow in and this is a Journal of Orthopedics, right? But we also found out that the ones that it fails on, it's because guys had a BMI above 27, right? Where if you have a BMI above 31, like even the soft T wide or the EMT or, it could not stop your flow. So the fatter you are, the less chance you have of a tourniquet working on your shit anyway. Right. So it's pretty.
You're in good company here. We fat shame all the time.
Yeah.
Yeah.
It's our thing.
Okay. The next thing is the windlass mechanism of this cat, right? So I have a cat here. The windlass mechanism of this thing, which is this little bad boy here, right? This part here. The windlass mechanism, right, that turns, right, only has a distance of travel of about 30 millimeters of compression when correctly applied, right? Which is insufficient to get enough pressure onto a thigh. Right? Like we figured that out. The limb was in the limit of 30 millimeters of complete closure with as many twists as possible on this thing. That 30 millimeters of closure is only about that far, right? The limit was reached before discomfort, precluded further testing. It was backed by presentations of casualties in field hospital that had broken windlasses from over tightening or whatever. But you also have to understand that even though the cat looks like it's that wide, right? You think that the cat is that wide, which is like, that's an inch, right? Like we all know that that part is an inch from your finger from here to here is about an inch. So that's about an inch wide. But remember, in essence, this is the part that's tourniqueting, right? I don't know if you can see that little part that's inside here. That's what gets pulled. And that is smaller than that inch. So that's only 2 centimeters wide. And then once you start twisting that, what happens to that 2 centimeter wide thing? It becomes 550 cord.
Yeah.
So in essence, that picture I showed you at the beginning where that guy had the bilateral amputations and he had the tourniquets on that they were tightened all the way. In essence, it was 550 cord around that guy's thigh. So imagine what the width to circumference ratio is with 550 cord and how much pressure would be necessary. You would crush tissue. You would crush vessels. You would crush nerves. It's worthless. This is a worthless piece of kit. And I can tell you that I have been around long before this piece of kit. And I know the people who invented it. And I know the studies that were done that implemented it. They were like, what do we want as a tourniquet? Because there was a bunch of CAG medics that were like, hey, we're going to implement this. I don't want to, bust Ted out, the old CAG medic. And he has a big influence on how this came out. But it was, what do we want? We want it black. We want it Velcro. We want it to be able to be put on by a single guy because we operate individually. I want to be able to put it on myself. You know what I mean? We want it to be able to be tactile, small enough, cheap. They never once said we want it to be effective. based off data sets, right? So there's ways, but I get it, right? Like I used to give this class to medics all over the country, right? Like I would travel places and units would bring me in and I would give my classes on, patient presentation and patient assessment. And then we do that for a while, but they get, after 50 reps, they get kind of bored. They start bullshitting with each other. So I'm like, all right, come in. We'll do a class on tourniquets. Then we do it again. Then we come in and do a class on needle D. And then we come in again and do a class on blood products. And then, but when they do this one, they're like, well, what are we supposed to do, doc? Like, we don't buy shit. This is what they give us. Right. So I'm like, okay, well, let's talk about how to at least mitigate some of the risk, right? Like, how do we, cause this could still be used on my arm, right? Like I'm a skinny guy. A cat can work on an upper extremity. I have no problem with cats being put on upper extremities, right? But let's talk about how they fail, right? So this is the biggest reason why they fail. This right here, right?
Plastic
double buckle. It's plastic, but it's a double buckle, right? So what happens when you feed this through? What do they say? You're supposed to feed it through the bottom and then feed it back through the top like a belt, right? Like, and that belt system is supposed to get you, let me see if I can get this fed in here for a second. This is a brand new one.
You're failing.
Stop making excuses.
Really
just
all those
do
classes
it.
where you have to do it quick. You're
Get your
failing.
shit. Go to station one there and show it's brand new. What other excuse you got? It's out of so we didn't prep a year before the event.
This way, yeah. You're supposed to feed it through this way and then feed it back on itself into this way, right? Mm-hmm. So now it's tight, right? Now it's tight. You see that? That's how you're supposed to do it. So what happens? People put them on. They slide it on the guy. They feed it in, and then they pull this on the guy and then cinch it down. But what's going to happen, right? This pressure on this, if I put that on myself, on it, this pressure is going to stop before it's fully tight. And then it's going to rotate on the guy. And what are they going to do? They're just going to Velcro it and start twisting. Right? So the first thing I tell guys to do is to don't double feed it. Single feed it, right? If it breaks, get another one. Right? Like single feed. It's just because you mitigate that particular risk of it stopping as you're pulling because of this part exceeding the pressure on this part exceeds the pressure on the pull. So it's just going to rotate, and it's just natural human, response to stop, pulling it and do it. So single feed it into the top, right? And then pull it. Now you can pull it, and you can pull it as tight as you want. Right? So that's step one. Step two is always pull towards yourself. Right? Because what'll happen is same thing. Guys will pull away from themselves. They'll get to the point of stoppage and they'll just Velcro it and start twisting again. Whereas if you're pulling it towards itself, you can put your hand on the guy's thigh as you're pulling, push away with your hand as you're pulling with your thigh and really torque down. Like you got that push-pull motion like you're pulling a bow. And you can get, so 90% of the torque and the tension that you're building on the tourniquet is coming from that initial pull. Like you're really getting a lot of pull. Then you Velcro it. Then you only have to turn it like do it to each other. And you're like, okay, if I just did it, how many turns can I get? But if I crank the shit out of it and do a couple turns, like he's going to be like, dude, stop. Right? Like, cause you want to get most of it with that pull. Right? So those are three things. Single feed it. Pull towards yourself, right? And down. So those are easy, right? So those are your mistakes. So, do it towards yourself, single buckle, right? Let's see. What are the other ones? Fixes, whatever. That's it. Again, yes, Trent. Yes, sir. Yes, sir.
Some of the other stuff that was thrown out there. See, I'm just curious because like there's certain things that I still carry around or have, in places that might be nonsense, including my tourniquets that I have all over the place. Like we were also told like in a pinch, you can use like electrical tape. And so in my brain right now, I'm like, if I do electrical tape and keep tightening it over a wider area, would that work at all?
Well, think about as if you do electrical tape and you put something in it and twist it like a tournament.
No, you just
every
keep tightening
time you
it.
Twist it, it's getting.
You
keep. Okay, we'll talk about that. We're going to talk about that here in a second. We're going to talk about that here in a second. So we're going to talk about the data. So they did USAIR, which is the United States Army Institute for Surgical Research, did a study on all the tourniquets. They did the EMT, which is that pneumatic one. They did the CAT. They did the SWAT T, the soft T wide. They did all these, right? And do you know what the number one tourniquet that they found in that study was?
Duct
Surgical
tape.
tubing.
Oh.
Like the big 1/4-inch surgical tubing, right? That they used to use from the Civil War, right? Like you would use it for IV bags and stuff in the Civil War. And what they would do is they would wrap the surgical tubing around circumferentially in a spiral because it would get wider and wider with every one. And eventually they would reach LOP at smaller pressures, right? So that was the number one. What they found out is, like I told you, that's when they did the popliteal artery study, and they found out that, less than, 8% or less was actually stopping popliteal flow with a CAT, right? And it was 0 on anybody with a BMI higher than 27, right? But what they found in that study was they're like, okay, so with the data went out, right? That in that triangle that we talked about at the beginning, the data, the performance was like, okay, these all suck. They got the data. They sent it back to the instructors like, all right, man, well, let's stop giving cats out and let's get those EMTs. You know what I mean? What do those things run? And they're like, oh, they're $350 a piece. Or how much is a cat? $6.
Yeah, $5.
Yeah, fuck them. Give them 2, right? Like that was the answer. They're like, we're going to give EMTs to our medical personnel. So we want our medics to carry EMTs, and we want our Joes to carry cats. So just carry 2. You know what I mean? Like, we're not spending $100 million on fucking tourniquets. You know what I mean? And then all this data came out and the medics loved them until they started using them. And then they were like, okay, these things are $350 a piece. So what do you do as a platoon sergeant of a medical platoon? You're going to put it on the inventory, right? And it's going to be an inspectable item. But then you start putting it on casualties and sending it up like, oh, I don't have my fucking EMT because I sent it with a casualty. Now I don't have anything. And we only have 6 in the inventory. You know what I mean? You got to get it from your squad leader. Like it was such a big, so we just stuck with the cat. It's 100% a money thing, right? But what are you going to do? Right? Like that goes back. So again, the first thing is, bottom line is 2 on the leg, 1 on the arm, right? So the first thing you do, what I tell my medics is get them as close together as you can, right? And then make sure you 3-inch shape, 3-inch shape them or whatever, and let the guy know. So if you put them close together as you can, you're in essence turning, making a 2-inch wide or 2.5-inch wide, is even if they're not touching, if they're a little bit apart, you still are compressing enough that you're going to increase your chances of having a lower pressure to reach EMT or LOP. Because in the school that I ran, we had a fake leg that had pressure sensors in it. And what we would do is we'd put different tourniquets on thing, and we had the pressure set. It was either a 1, 2, or 3 on the computer. So it was either a CAT, a soft T wide, or a EMT. And the computer knew when you reached LOP because the pressure, the sensors that were in the fake, the rubber Dextol looking ones, you know what I mean?
Yeah.
Like there was pressure sensors in. So as it squeezed, you would hear an audible beep and the red light would come on when you reached LOP. And I can tell you that when we turned off the red light and the beep and the instructors were just looking at the number pressure that they were due, not one dude in the class of 50 got a CAT to the LOP necessary to reach a pressure necessary to reach LOP. Not one. 100% no-go on that station. But as soon as we turned on the red light and the audible beep, and they kept going till they hear that, they're like, oh my God, you really got to crank these things down to get that. We were like, yeah, like they were like, I've never turned it that many times. I've never put it on that many times for a dude. Because what are we doing in training? I'm putting it on you. And after 2 turns, you're like, bro. And so we're literally training ourselves to be horrible with a horrible piece of kit. We're training ourselves to put it on even more horribly by, you know what I mean? By going left leg and then just doing it. Like you're not training a dude for the skill set to use the proper piece of equipment. But there's other options, right? You have your soft T wide, right? Like these are obviously wider than a CAT, right? And the thing that's actually doing the turning is metal, so it's not going to break. And the piece that's actually being tourniqueted is wider than the entire thing. There's not something inside of the sleeve that's going to get more narrow. So the entire thing is doing, so at least this thing is 1.5 inches wide. Then you have stuff like the SWAT tees, which I know you guys love because it was invented by a PJ who I know, right? But in essence, you can get this as wide as you want. Like you could make this into a 7-inch wide, like you just wrap it in a circumferentially and a spiral, and you can get it on the entire thigh, and they still make good pressure dressings at the end of the day. But you can also get the same thing with a 6-inch ace wrap. by going super tight and doing a couple wraps on from here to here to here to here and making this 6-incher into 16 inches, right? So, and again, you're going to get LOP at diastolic or subsystolic pressure.
But then you would have to explain to people that there's a time to do ace wraps tight. And then people might get confused because aren't you not supposed to do ace wraps too tight? Because you're not supposed to.
Well,
I'm here representing all the idiots.
I can tell you this. Yeah, I can tell you this. So this is my personal IFAC, right? Like me and my wife go shooting. We go up to the range. And of course I take an IFAC in case the idiot next to me or my wife decides that today's the day she didn't like me bitching about her cooking, right? Like I take my IFAC. And what's in here is I have a little thing on the bottom for a soft T wide. So I keep that on there. I have a SWAT T in here just in case I have to do a bigger pressure adjusting. But what is inside this IFAC is literally just Curlex combat gauze, 6-inch ace wraps and 3-inch tape. So there is literally no thing that I can't take care of with Curlex ace wraps and 3-inch tape. I've yet to find an injury that I would need a tourniquet on. And I can tell you, I have been doing this for a long time and I have been in a lot of point of injury scenarios where I didn't even think about busting out a tourniquet. Right. And it's just not something that I ever even thought of. This is going to be something that I really wish I had a tourniquet right now. Like you give me enough ace wraps and 3-inch tape and 6-inch, and Curlex, I'm gonna be able to do everything I need to do. All right. So now this is the point where you need to put the, not safe for work disclaimer on your things because we're about to get ugly. Okay. So if you are squeamish and you don't like stuff, please exit the podcast and come back in 10 minutes or whatever. Right.
Make sure you subscribe.
So
I feel attacked.
Make sure you subscribe first. Like
make sure you subscribe on the way out.
Right. So this is, I don't know if you can see this. This is an IED casualty. Is this going to change? Yeah. Okay. So this is a dude that was, obviously died instantly. This falls into that category of non-survivable. You can see he's got bilateral amputations and in essence, he has hemipelvectomy. He's got no junk left. It's gone into his pelvis. So this guy was killed pretty instantly, right? So you can see his wound here. So the first thing I want you to notice is this right here, right? You see this kind of mush. So remember when an IED goes off, the first, we read a lot and we discuss a lot about in military trauma, about mine blast trauma, right? So remember when something explodes, you have the shock wave, then you have the dirt and dust around it, and then you have the shrapnel and the explosion itself. So there's in essence 3 levels of damage that get caused when something blows up, right? The initial shock wave, the dirt, dust, and whatever's in the atmosphere, and then the actual explosion or shrapnel of the device itself. Right. So that initial shock wave creates this right here, which is a big ball of mushy fuck, right? Like this is just mush. If you were to grab that and pick it up, it literally would fall through your fingers like jello, right? Like silly putty or, what's the ooze from the TV shows, the kids TV shows, slime meat, right? Yeah. It would go through you like that. Like if I grabbed that guy's leg, it would just kind of go through. Because remember, your cell structure, it has, if you remember basic anatomy and you did cells, they have a lipid layer around the cell, right? Every cell it contains that lipid layer. But when that shock wave goes through, it kind of damages those lipid proteins that hold it together and the cells just kind of come apart. And that's what tissue looks like when it does that. So you can see this right here. Look where this guy's left hand is, right? So that is probably where this guy had a uniform on, where that dude would apply a tourniquet because he felt leg and he applied the tourniquet. But look above that up here, right? That tourniquet would have done nothing, right? Because if you look at the TCCC guidelines, it says put on the tourniquets above the clothes, as fast as you can, right? I don't like that because I'm a trauma guy. I say it's just like an enemy, right? Like you put eyes on before you hit a target, right? So the first thing I do is I'm real big on seatbelt cutters or, deer skinners. I like the big ones like this that you can get your whole hand in, right? And we do a lot of classes where we go to DRMO and buy a bunch of shitty uniforms and put them on all our dudes in training. And you have to train your guys to disrobe a casualty. Even if it's just down, you pick up a little piece of cloth like this and cut a hole in it, stick your finger in that hole, stick this in that hole, and go all the way down, right? So I do it on the shoulders, boop, all the way down the sleeve, do it on the leg by the groin, pick up a piece of fabric, cut a hole, boop, stick your finger in that hole and run it all the way down the leg. So at least you can fillet open the arms and fillet open the legs, right? You don't have to totally disrobe the guy, but you have to expose the wound. Because if you expose this wound, you would know right away that there's tourniqueting working on this guy, right? Like you can see this right here where the guy's left hand is. That's where you would want to put a tourniquet above the amputation. But if you look above that in the pelvis, there's obviously damage there, right? Like right here. See that? That's above. You know what I mean? That needs to be packed. Like
what a shitty wound. Oh, what a shitty wound. So first of all, I can smell all of these pictures and they're disgusting. Like I'm literally having a time in the head over here.
I can tell you that, I have been at point of injury and dealt with a very similar patient. We were in the 101st, guy named David Bixler, and he survived this, right? And I'll tell you exactly what I did to him. He absolutely was in the non-survivable category, and he survived at point of injury. I'm not going to say
Did you say not on my watch? Did you scream at him, not on my watch? You should have. What the
I really wish that I would have screamed that out to everybody involved. So what I did when that happened, what I did when that happened is I yelled at all the dudes around me because obviously there was now 10 guys because we were just on patrol. The guy stepped on ID. So there wasn't a firefight. It was just one boom, boom. This is what happened. I went there and I immediately pulled out my seatbelt cutter, stripped the guy's leg down, saw this. And I'm like, okay, tourniquets ain't working on this guy. So I had everyone open up your IFACs, pull out your Curlex and give it to Trent. Trent, you're going to open him up and make him into a big ball of fuck, right? Like pull out the center, you know what I mean? Do one of those numbers and make it in and just puff it up. And they would give it to Trent. Trent would open him up, puff him up, hand me the big ball of fuck. And I just started packing this guy. Took my 6-inch ace wraps, went up the guy's leg like you saw in that first one, and literally made a diaper around this guy. Packed him with as much Curlex as I could, and literally made a diaper of 6-inch ace wraps around his legs and around his groin. Put him on a bird. We even said, no way this guy survives. No way this guy survived. Right? And then, but they were like, hey, he made it to the roll 3. Hey, they did his thing. He's alive in the freaking ICU. Hey, he's going to launch till tomorrow. Hey, he's on his way to Walter Reed. And then he met us, 9 months later in his chair with the little, wheels coming out there. And then we were like, how the fuck did, that was not supposed to happen. Right.
How wild was that for you,
you saw that guy,
when you linked back up with him?
It was pretty wild. Well, I can tell you this. There was a plethora of dudes that I saw on the other side that were like, thank you. And it's very weird, right? Like nobody wants recognition for anything. And, they're like, dude, and I'm like, okay, good to see you. And you're like, I don't really think about those dudes as much as I do the, 19 people that I couldn't, what I mean? Like those because those are the ones that you replay. Like, what if I would have done, had I, should have, would have, like those are the ones that kind of weigh on you more than, how many you do. Cause I mean, you do trauma for a year in a trauma center. Like, you're doing 5 a day. You know what I mean? Yeah. So how do you even recognize, anything good? All right. So you remember that first picture where the guy's hand was on it like this, right? So what I want you to remember is that's the top of the leg. Now look at the bottom of the leg, right? So that's underneath and up, and you can see how high it goes up into his butt, right? Like you are not putting a tourniquet anywhere near that guy. And obviously this is a dramatic case because this guy didn't survive or whatever, but it's just the same thing happens to anybody that has a below the knee to a lesser extent. It'll go up the hamstring, it'll go whatever. So number one, you've got to put eyes on shit. You've got to cut clothes off. You got to look at what you're doing before you do. And you got to start, like you could do a combination of a tourniquet and a pressure dressing on all these things and pack the hell out of it or whatever. Right. And like on this guy, what would I do with this guy if he came in? I would externally rotate that wound on the thigh. I would identify, you can see right here, that's the femoral artery. I would identify that, clamp it, pack it, or whatever, and you're good to go. Right. So, I'm not showing you this to say, look how cool this stuff is. I'm looking at it. So if you don't put eyes on, the things that we are taught to do aren't going to work, right? Again, pressure dressing are still what drives the train, right? Curlex ace wraps, 3-inch tape, they still are better than any piece of kit that the military has yet to do. You know what I mean? Like 6-inch ace wraps and combat gauze. Like I literally have, and when I went out on patrol, I would get these combat gauze and I would have 15 of them in my little belly kit, right? Like under my plate, I had a little pack like this, under my plate carrier, that hung down. And I would just take these things and fill them all the way to the brim, all the way across. And then and I would put as many 6-inch A straps and 3-inch every dude on the patrol would have 6-inch A straps and 3-inch tape in their shit so they could throw it to me if I needed it. Right. So I had a huge aid bag of dudes around me that could hand me stuff. And if I worked on them, I knew they had a bunch of 6-inch A strap, 3-inch tape combat costs that I worked. Right. So I'm not telling you this to say, tourniquets suck. Don't use tourniquets. Like I tell you, I have a soft T wide on my shit when I go to the range in case I have to use it because I don't want to use all my tourniquets or whatever, Curlex and A straps and some rando in the stall next to me because it's right down or whatever. So they're still viable and they still work. I've never been a fan of the cat and I never will be a fan of the cat because I've read the data and you can't show me one piece of data that says cats are legitimate. You know what I mean? It's simple math. You can give me all the cool, because obviously the people that make cats are going to create data and have studies that say they work kick ass on animal models and whatever. But at the end of the day, you can't beat math, right? Like we know that they're like the width to circumference ratio is what drives the train. And a 2 centimeter wide thing on let's say you got dudes on teams that are 6'4", 240, man. Like you're never going to get LOP on it. Even with 3 cats, you're not going to get LOP on that guy. He's a monster, right? These dudes hit the gym every day. Like you're in Brazilian jiu-jitsu with dudes who have thighs that are like Walter Payton, man. Like you're not going to get LOP with a freaking piece of 550 cord on that dude's legs. It's just not going to happen, right? So what do we do in spite of that, right? We go as wide as we can, right? Like remember that old, Pontiac commercial, Iuhu Akaula, about the Grand Am because it had a wider base. It was like wider is better. Like you guys are young. You don't understand.
They had the whole wide
You've probably never seen a
car.
Grand Am commercial in your life. There was a commercial in the 90s for the Grand Am because it had a wider wheelbase and then they drove by an Eskimo and the Eskimo was like, Iuhu Akaula, wider is better. And that was like their logo. So wider is better. Anytime you're talking about trauma and stopping bleeding, like you can, in essence, I told you the best tourniquet out there was just circumferentially wrapped IV tubing because they went all the way down the thigh and they got LOP at a lower millimeters of mercury pressure, right? Pretty simple. Did that blow your mind, Trent? Are you now like, what the hell, man? They've been lying to me my whole career.
It's really not that surprising that I've been lied to my whole career. But it's just like everything else, like they oversold the tourniquet, when we went through all of our courses. It was a magical piece of kit. The data they gave us
because it was like, we have something that civilians don't have now. And you know what I mean? It's like, who are the people that benefit from that information the most? The people who sell a tourniquet. Like how many tourniquets do you think they've sold since the 90s? Right? Like every dude in the military had 2. And then how many for training? Like we have created billionaires on that one piece of kit. You know what I mean? And but at the end of the day, does it really matter? You know what I mean? I mean, and you would hear stuff and let me dispel a couple myths right now, right? Like, we would do classes and the sergeant majors come on there, like I visited people, Walter Reed, who still had their tourniquets on from, point of injury. And I can assure you that is bullshit, right? Like as a trauma guy, what's one thing? You've rotated through the hospital, right? To do your PJ rotations, right? What's the one thing you remember from those rotations? Wherever you just came from was the worst place to work. Oh, I wouldn't let that surgeon work on my dog. Oh, orthopedics, I wouldn't let that guy do my ankles, right? Like, oh, dermatology, that guy's a moron up there, right? So in essence, every level of medicine, everybody below you is a complete fucking idiot. So we're not going to let, like you PJs, what are you going to do in the bird? You're going to cut off everything that medic did and you're going to reassess the patient. What are you going to do when you come to the roll 3? I'm going to cut off everything you did and I'm going to reassess that patient. He's got to go into the OR. So what's he going to need? He's going to need a chest tube. He's going to need advanced airways. You need a Foley catheter. He's going to be completely naked. He's going to be washed out first. He's got to get all the crap off, all the kit off of him. We're not going to let him go into an OR with dirty ass tourniquets and dressings from point of injury. Don't be ridiculous.
Right. Yeah.
Like
that's just the most ridiculous.
Start anew. Yeah.
Right.
On a side note, head on over to onesready.com. We're now selling surgical tube.
Right. Yeah. We just got that on the site. What's up? Surgical tubing.
Yeah.
So much better than
I mean, again, there's probably guys that watch your thing that go to the range that have IFACs that make personal kit and have kit or whatever. And I just, if you're going to redo it, like, dude, just buy a bunch of combat gauze, buy some 6-inch ace wraps, buy some 3-inch tape, and then go practice putting on pressure dressing, right? Take your Curlex in your combat gauze, turn it into a big ball of fuck, like a sock. Like if you're just a ball up a sock, pull that Curlex out and make it long and then put it together into a ball, press it into the thing, take your ace wrap, go around it, pull as tight as you can, go around it, pull as tight as you can, make an X over it. I'm going to go this way, pull down, go this way, pull down, go this. So now you have, if you do that, you'd be like, oh my God, that ball is super tight, super hard. Like that's a sufficient pressure dressing, and practice that over and over. There isn't a wound you can't take care of with a good Curlex tourniquet, Curlex ace wrap tape mix, right? Like it's just, I mean, if we can gin up David Bixler and save that dude's life, bilateral amputations and not use one tourniquet, then show me an injury that's going to need one. You know what I mean? Like granted, I'm probably a little biased because I've seen them fail way more than I've seen them help people. And I mean, we started out the class with a picture of 2 failed cat tourniquets, right? Like I don't want to get sued by the cat people by say they don't work. So I'm going to end the tourniquet discussion with this one disclaimer. Everything I just told you to was a lie.
This is fake news.
Allegedly. Yeah. This is all misinformation.
Everything
It's covered by the Smith Mundat.
I made up every piece of that.
Every piece
now
of it.
Trent's like, well, what the hell, man? And the only reason I say that, and that's something that last slide when I give that class, is all of this was bullshit. So how do you know who's true and who don't? You don't. Don't trust anybody. Go read the studies. If you're in the military and you're a PJ, 18 Delta, 68 whiskey, whatever, take your luxury that you have by having access to military computers and start an up-to-date subscription. Get on Ovid, PubMed, and you can get every journal in the Journal of Trauma, the Journal of Orthopedic Surgery, the Journal of anything, and you can read all the data. Then you can do what I did, right? Read the study, read the references that the references reference. Until you can do that and disprove everything I just said or prove everything I just said, it's on you to do the research of what this is real. What's real in this? Give me every study that's ever been done on tourniquets, whether it's in orthopedic surgery, in Journal of Trauma, in the emergency room, in tourniquet, at point of injury in medicine. I'm going to read them all and I'm going to put together my own philosophies on what works and what doesn't work, because there's new studies out, right? We have 20 years of Army military data of studies that have been done based off of that. There's people that have embedded and done studies. Go read everything and prove it to yourself of if I'm right or if I'm wrong. But you can't argue math.
You're right.
You know what I mean?
You're right.
Does that make
sense?
sense?
Argue math, homie.
And
it does.
Again, I don't want to, because I don't want to come across as a subject matter expert. I'm a PA. I don't know shit. You talk to a trauma surgeon, he's going to look at me and be like, Scott, stop talking. Like, stop talking. But remember, at Vanderbilt, they would make us stand up every Thursday and give them classes so they could personally put holes in all your shit, right? Like, and there's no way I'm giving this class to a trauma surgeon unless I had studies to back up the things that were coming out of my mouth, right? And done the research and whatever, right? Does that make sense?
Sure as hell does, brother. No more tourniquets, and you can't fudge math. Math don't lie. Scott Zastrow, thanks for all your help, man.
I'm not saying don't use them. I'm not saying that. I'm not saying don't use. I'm saying that they're viable, but if you're going to use them, get the widest ones you can. If you can find those EMT, those pneumatic ones, those are great. I'm sure there's people like if one's ready, wants to become super rich, make a one's ready tourniquet that's a cat, but this wide.
Nice.
We're gonna delete that part of the video. Actually,
yeah, that's my IP, baby. That's what we call intellectual property, baby. We own that now because we are on record. So we gone, baby. I'm gonna be like F Young Bowling and make the foxtrot litter.
Yeah, exactly, man. I mean, it's. I mean, and we could do another, class. I can tell you why needle D's don't work, and do the same thing with all the data and all the studies or whatever, man.
Let's go.
I'll poke holes in everything.
Trent's out of here. I was going to mention needle D earlier too, because it's the funniest thing. You take an 18-year-old with a GED and you don't give him any background on what it is that he's about to do, and then you allow him under the guise of medicine to put tourniquets on that are potentially damaging and then access the chest. And we're like, that's frontline stuff. Here's what we're going to do with no medical training. I'm going to teach you how to access the chest, and I'm going to teach you about tourniquets, which could possibly hurt somebody. So fantastic, Scott. We are going to get you back on for that for that needle D discussion. Everybody say thanks to Scott.
Scott, like that one.
I'm not, dude. I don't care. I love it. I burn it out. I was never a good medic anyway. I let my paramedic cert slip. I'm not even qualified anymore.
Yeah, let's just rehash everything we just talked about, right? So number one, the one thing I want you to be able to do is, we know you're all morons. We know I'm a moron. If I'm a moron, imagine what you are and what Trent is like below me. Like, I've done a lot of this, a lot of my life, and I can still consider myself terrible at it. You know what I mean? There's still so much. Medicine is one of those things that you can be Doogie Howser and start when you're 9 and go to your 90 and still not learn everything about the body. So anybody who thinks they got the system beat is full of shit. You should not trust that person whatsoever. Right? So number one, but at your level, there are things that are within your level that I expect you to be really, really good at, right? Like my motto, be great at the things you're supposed to be good at. I don't expect you to be good at the things in my lane, but I expect you to be way better than a normal human being at the things in your lane. So be great at the things you're supposed to be good at, right? Number two, learn how to talk to providers. Learn how to present them, right? Like, go to them and ask them, how do you want me to present a guy to you? Right? Like, talk to the dudes in ortho, in derm, in freaking psych or cardio or trauma surgeons. Like, hey man, if I called you from downrange and said, I got a guy, what information is relevant to you? Like, how do you want me to present them? Like, I don't want to present them in a soap format. Like, there's particular information that are important to you, right? Like, go read Netter, go read this stuff, right? Like Netter's anatomy, right? Like there's books out there. The Netter's orthopedic anatomy, absolute must, because there's presentation in there. These are the information that orthopedic guys like. So get a Netter's, right? Learn to ask the right things, right? Like of the people in front of you. So if I'm transferring a guy as a point of injury guy to a PJ, you know what I mean? Like, if they don't tell you the things, ask, right? If they don't learn to ask the right things of medics at point of injury, if they don't give it to you, ask the pertinent things. If they don't give you the ADCs, ask the ADCs. Like, does he have a patent airway? If so, with what? Do you use NPAs? You got an ET tube? Do you crank them? Like, what's his airway maintained with? Is it something I'm going to have to do when I'm en route? You know what I mean? If it's a chest injury, why can't I see the chest? You know what I mean? Why if you did needle, you know what I mean? If you did a needle D, why? Right? And at the end of the day, read every study you get your hand on. If it's in your lane, you should know everything about it. If you're supposed to do tourniquets and needle Ds, you better know every piece of information about a tourniquet and needle D. If you're supposed to be doing splints and dressings and whatever, if you're supposed to be doing burns, you should know everything about that. Like, that's in your lane. Be great at what you're supposed to be good at. You know what I mean? Like, I really wish if we could focus on more of the stuff that we're supposed to be great at in our lane, as opposed to trying to prove to people hiring us how smart we're supposed to be. You know what I mean? We talked about that about 18 deltas and PJ last time, that they have this, perception that we can do, that we're masters of everything, and it's too much. You know what I mean? But I can tell you, I'm really good at using these, and I'm really good at making phone calls. You know what I mean? Which is what I have to do as a PA, right? Like, I have to present to dudes as a medic. I have to present to dudes like everything. Data, man. It's very data driven. Well, thanks for having me back,
brother.
I appreciate it.
No, it's awesome. Thanks for everything that you continue to do. Yeah, it's good to see you. We'll get you back on for the next one. I love it. It's the bug has got you, Scott. Like, you have looked at it. You're like, hey, you know what? I want to get this information out. I bet I know a guy. You do know a guy. So
like I said, I did this for years, man. I did this for Army medics. I ran a school for Army medics, and we would discuss this stuff all the time. I taught all my 18 deltas, and we discuss this stuff all the time. And you can see the light bulbs going off in their head. And then you can see guys getting angry, like, I've been lying. Like, and it goes back to what we said. It's enlisted guys teaching enlisted guys with no thing. Like, when hey, you're going to go work at the schoolhouse and you're going to teach these medics to do this. Here's a binder with your PowerPoint slide on it. You're teaching tomorrow at 10 o'clock. And you're like, Roger that. And you just sit there and flip through slides and you read it. And if somebody asks you a question you don't know, you just make it up as you go and hope that they don't bust you out and call you out on it. You know what I mean? Because I would go sit in those classes. The guys would ask questions and the guy would answer. And I'd walk up to him after and be like, you have no idea what he just said to answer the question he asked you. You know what I mean? So guess what you're going to do? You're going to go read a study on it and then read the references and read the references of the references, whatever. And you're going to be able to answer those questions intelligently. You know what I mean? That's the problem.
I think one of the reasons this is so important as well is there's a huge push for folks that have never been in the military to be prepared more than they've ever been before, right? Like, all the folks that have never been in, they trust, if you say you're a PJ, an 18 Delta, a Ranger medic, they take everything you say as gospel. So
Absolute
for those
gospel.
folks to hear it from y'all that like, hey, this isn't gospel, this isn't 100% solution. There's a better way to do things, and for people like me who took everything as gospel for years and years and years and had like a strange sense of confidence just having a tourniquet on my body all that time, now knowing what I know was kind of silly. I think it's really important for those folks too that are out there that are not going to be in the military and to realize what the truth actually is.
Oh yeah. And I mean, as Deltas, we do fit a lot and we do a lot of stuff around, like we do a lot of JTF6s. We work with police, sheriff, SWAT teams or whatever to give trauma classes and go do shoot house stuff with them. And they would always have me do, a patient assessment class. And I would always give this, and they all have like the Kydex tourniquet holders on their kit. And you can just see them all in the back pulling that off and throwing it behind them in the trash. And you're like, well, screw that. I'm getting a full IFAC with Curlex and ATRA. Because as soon as they start putting them on each other and they start seeing that when they tighten it down, it becomes 550 cord, they're like, yeah, I don't want anybody putting this on me. You know what I mean? Pack this wound, right? Like here, give me that 6-inch ace wrap, bro. Like go wide as you can. You know what I mean? Because there's a lot difference of doing this with a 550 cord or do this with a 6-inch ace wrap to get the exact same LOP, right?
Yeah.
Like it just makes sense. So
do it for your friends. If you end up in Scott's triage and he puts a tourniquet on you, that means he hates you. So that's the big lesson here.
He wants you to die and hurt while you do it.
Just read, man. Get the studies and read the studies. If you're somebody out there that is prepping or, you're not in the military and you see this, like go read the studies, man. Like it's all open source information. You know what I mean? Yep. Like do it on yourself. Do it on a log and watch what happens to that inner thing. The more you twist it and how tight it gets, and be like, there's no way mathematically this is gonna get to, the limb occlusion pressure at 700 millimeters of mercury pressure. It's just not going to happen. You know what I mean?
Damn right. Scott Zastrow, thanks for your time, brother.
I love it.
Thanks, man.
He's impressed. We'll see you next time, brother. Everybody else out there, go ahead and head over to onesready.com. Find us wherever we are. Leave us a 5-star review. That'd be awesome. Leave us a nice review. It's not the time to be funny and say something cute in the comments because that actually hurts us. So don't do that. Anyway, thanks. See you next time. Train hard.
Later, y'all.